In the acute maxillary sinusitis of dental origin, meaning the source is bacterial, we prescribe antibiotic to convert the condition from acute to chronic, plus removal of the cause or the source of bacteria, whatever by endo or extraction. Decongestive nasal drops. Decongestive means it is against congestion due to widening of blood vessels. The medication usually made vasoconstriction, so decrease the edema of the sinus lining. Analgesics to relieve pain and anti-inflammatory as well, like NSAIDs, non-steroidal anti-inflammatory drugs. The antibiotic course at least should be 5 to 7 days. If there is orantal fistula, that will be discussed later in details, we should do daily irrigation of the sinus by warm normal saline, and removal of the cause, as we said, like closure of the fistula, removal of the infection. Chronic sinusitis, we perform extraction of the infected tooth with sinus enucleation, sinus cyst or periapical infection enucleation. Repair the fistula as well. Surgical removal of the second lining through Caldwell operation also, it will be discussed later, and it involves removal of the second lining and promote healing through formation of new healthy sinus lining. So here we can notice that the main difference is the antibiotics which is only prescribed in the acute condition, and the common factor is removal of the cause, which is the most important factor in the management of maxillary sinusitis or any infection. So what is the problem of maxillary sinusitis? What is the complications? Complications involve orbital cellulitis, meaning inflammation of skin and facial spaces around the orbital cavity and its contents, like we see in this photo, or subperiosteal abscess, spread of the infection from the soft tissue to the periosteum of bone and formation of abscess below the periosteum. Subperiosteal abscess over the maxilla or the orbital surface. Orbital abscess, more spread of the infection forming abscess. Mastoiditis. Mastoiditis comes from the mastoid process, as we'll see later. Here is the mastoid process behind the ear lobule. The mastoid contain mastoid air cells that receive the infection from the eustachian tube within the oral cavity. To understand the sequela of maxillary sinusitis infection to the mastoiditis complication, you have the maxillary sinusitis infection spread through the nose, and the nose to the oral cavity, through the nasopharynx, to the eustachian tube, to the middle ear, and the ear communicate with the mastoid air cells, causing mastoiditis. Here is infection clinically, mastoiditis. Moreover, the infection can spread to the bone itself, forming inflammation of bone and bone marrow, what's called osteomyelitis, inflammation or infection of bone and bone marrow, causing maxillary osteomyelitis in case of maxillary sinusitis, or frontal osteomyelitis in case of frontal sinus infection. Here is frontal sinus infection. Also the infection can spread to the cranium, causing subdural abscess or cavernous sinus thrombosis, or even brain abscess, through the venous communication from the facial surface to the intracranial region. Here comes a question that we already answered a part of it. How does this infection spread from the maxillary sinus to cranium, orbital, or even mastoid process? We said the venous structure, we have the anterior facial vein. The anterior facial vein that we said that it contributes to the venous drainage of maxillary sinus that spread to the pterygoid venous plexus posterior to the maxilla, that communicate directly intracranial with cavernous sinus, causing cavernous sinus thrombosis, subdural abscess, or even brain abscess. Here can we see the cavernous sinus thrombosis unilateral, and if we compare with the other side, we have normal cavernous sinus here, and this is swollen and infected cavernous sinus, and this is a serious infection due to spread to the intracranial region. third part, doctors, we have diagnosis of maxillary sinusitis. And you should know all that diagnosis of any pathological condition involve three main elements: history, clinical examination, and diagnostic aids. The history clinical examination help you reach the provisional or the primary diagnosis, and you assure or confirm your diagnosis with diagnostic aids like radiography or lab investigation or whatever that we'll discuss in detail. The history of diffuse toothache or common cold differentiate between odontogenic and non-odontogenic conditions or causes of maxillary sinusitis, meaning that patient have symptoms of sinusitis and has a history of toothache. After an inspection or examination of these tooth, you may find that is the source of infection to the maxillary sinus. If the patient declines the presence of any dental origin and the presence of only a viral infection like common cold, it can differentiate and give a provisional diagnosis of non-odontogenic infection. The duration of signs and symptoms the patient present with can differentiate between the acute and chronic condition. We said that acute is a disease lasting less than 1 month. 1 to 3 months is a subacute condition. More than 3 months is a chronic condition. And we confirm the diagnosis by clinical examination and adjunctive diagnostic aids. Also, the clinical examination involves three main elements: inspection, palpation, and percussion for both intraoral and extraoral sites. Meaning that for maxillary sinusitis, for an inspection, you should notice any presence of swelling, erythema on the facial surface or intraoral, the buccal mucosal surface, discharge from the nose or patient report posterior nasal drip, palpation to the periapical area in case of periapical infection spreading to the sinus, or palpation facial surface for any tenderness, meaning pain on palpation, or any swelling, or also should involve palpation to the lymph node on both sides. For palpation, doctors, you should compare with the normal side. To detect any abnormality or swelling, you should check the normal side first and the contralateral affected side later to compare between normal and abnormal. Percussion should involve the dental teeth for any periapical infection, the upper teeth related to the sinus, and the facial surface of maxilla for any tenderness. The diagnostic aids include radiographic imaging, trans-elimination, endoscopy, sampling like nasal lavage, cytology, biopsy from the diseased sinus lining or any lesion within the sinus or the periapical part of the tooth, allergy testing in case of non-odontogenic causes of sinusitis, mirror test. Will be beneficial later in case of oroantral communication and will be discussed in details. Lab investigation also in cause of non-odontogenic sinusitis, like allergen-specific immunoglobulin in case of allergic sinusitis. Starting with radiographic imaging, there are many views we can tell or screen a sinus condition, starting with the periapical and occlusal door for general examination to detect any root tips or foreign bodies. OPG meaning orthopantograph or panoramic view, also for general screening, any pathology in the sinus or root displayed in the sinus. BA posterior anterior view, Waters view is also called 15-degree submento vertex view. CT computed tomography, which is the gold standard for sinus imaging, and the coronal view is the most commonly used and the image of choice. Axial views may be indicated to compare if any pathology or infection in other sinuses like ethmoid or frontal sinuses. Magnetic resonance imaging to detect any pathology in the sinus lining, as the soft tissue is better viewed in magnetic resonance imaging. Cone beam CT is high beneficial in children due to its lower radiation dose than computed tomography, keeping that the same advantages of computed tomography. Before attempting to detect any pathology within the sinus, you should be able to read the normal anatomy or interpret it within the radiography. However, the sinus is an air-filled cavity surrounded by bone and dental structures. The body of the sinus should appear radiolucent within the radiograph and outlined with well-demarcated layer of cortical bone, and should be comparable with the other side. And if you suspect any pathology, compare it with the other side. If it's symmetrical, then usually there is no pathology within the sinus. Waters view is a kind of view that detects any fluid level within the sinus, any opacification, presence of ridge opaque lesions, as well as any sinus wall displacement, or even mucosal thickening could be appear in the radiography with soft tissue enhancement. Here is Waters view for normal sinus. You can identify bilateral symmetrical sinus lining. Here is abnormal with fluid level within the sinus, present bilateral due to bilateral sinusitis. Another view showing fluid level within sinus in water view, fluid level unilateral. Here is water view, here is submen to vertex view. As we said before, water view is 50 degree only submen to vertex. As we said before, computed tomography is the gold standard for radiography of maxillary sinus. It's usually indicated for preoperative assessment before surgery or detection of any anatomical variation, documentation and follow-up with recording bone measurements that's required, like bone volume density or even remaining bone height after dental extraction, planning and 3D studying before dental implant installation, any bone measurements, also CBCT the same but with lower dose radiation. Here is coronal cuts showing normal sinus bilateral. Here is unilateral sinus disease with mucosal thickening on the right side. Here is normal sinus in axial view. Compare the two sides. Normal sinus. Here is abnormalities axial CT cut showing a maxillary mass involving the maxillary sinus unilaterally. Here is fluid level unilateral. Here is occupying mass lesion occupying the sinus. Here is magnetic resonance imaging for maxillary sinus or skull, where soft tissues are enhanced and appear opaque, like the facial muscles and buccal muscles, rather than the bone, which appear more lucent. Another diagnostic modality other than radiography is trans-elimination, specific for maxillary sinusitis. Another name is Daphnoscopy. How it's performed: we place the patient in a completely dark room at the eye level with the observer and apply a flash of light below the inferior orbital ridge to look for maxillary sinusitis, and under the superior orbital rim for frontal sinusitis, as we'll see here. Here is we check the maxillary sinus. We apply the light over the inferior orbital rim to check for sinus, and clear sinus without fluid level will allow light transmission and can be checked from the palatal side if you apply the light on the facial side. And when you apply it palatal, you can notice the light on the facial side in case of clear sinus, while in case of opacity or fluid level or mucosal thickening within the sinus, it will not allow light transmission and it will appear opaque or allow no light transmission. In case of frontal sinusitis, the flashlight is applied below the superior orbital rim to check for frontal sinusitis. Sinoscopy is an adjunctive diagnostic method besides radiography and transillumination. It's important for diagnosis in early malignancy and any other pathological condition, and it involves usually utilization of thin flexible tube with a very small camera and flashlight to allow direct visualization of the mucosal lining and any abnormalities or erosions or polyps within the sinus, with the possibility of simultaneous harvesting of incisional biopsy from this diseased lining. Moreover, sinoscopy could be therapeutic like diagnostic as well. Diagnostic by performing a direct vision of the sinus lining, any abnormalities, or having a biopsy, and therapeutic by removal of sinus lining in case of irreversible changes occurred within the sinus, or even widening the ostium of maxillary sinus to promote drainages in case it's a therapeutic sinoscopy. Via sinoscopy, a sinus lavage also, or washing the secretions or pus within the sinus, can be performed. It's crucial to use a sterile saline to avoid contamination of the sinus with a very severe parasitic infection that's highly invasive that can spread to the brain, causing fatal infection. Here is a sinoscope with camera attached and a forceps, tiny forceps, to allow having a punch or incisional biopsy from the diseased sinus lining with the associated camera. And here is the point of application of a trocar, which is inserted on the thinnest part of the anterior facial surface of maxilla, which is the canine fossa. Here is the thinnest part over the facial surface of maxillary sinus, from which a trocar is placed. And after removal of the trocar, the sinoscope with the involved camera is inserted within this opening, and this sinoscope involves a forceps, a tiny forceps that can harvest any specimen of the diseased sinus lining to be sent for biopsy. Here is the medical drainage is encouraged through sinus lavage, external or through the nasal side. A sinus lavage can also be performed through sinoscopy. Here to sum up the management of acute sinusitis of odontogenic or bacterial origin, start with conservative treatment involving antibiotics, mucolytic agents, and antihistaminics in case of allergic sinusitis, and you should encourage medical drainage as we said before. If no response to the conservative treatment, we shift to the surgical drainage through antral lavage, either following sinoscopy or through an intranasal to clear the sinus from bacteria, pus, or even exudate that accumulate within the sinus and invite infection, using a 50 to 100 milli azote. Another option has to be used for surgical drainage is intranasal antrostomy, creation an antrum opening through the lateral nasal wall in the inferior part of the wall to promote dependent or gravitational drainage, but it's considered a radical solution that's no more used. Labial antrostomy or Caldwell lac operation through creation an ostium or opening at facial or labial surface of maxillary sinus, and incision of the sinus lining to wash or lavage of the sinus diseased contents, and even removal of the diseased sinus lining that has irreversible mucosal changes. Then reduction or closure of this ostium, while the most recently used is endoscopic sinus surgery because of its conservative nature. Chronic sinusitis management involves diagnosis and treatment of the offending cause, like improperly treated endodontically treated tooth or infected periapical region, or undiagnosed remaining root that have been pushed within the sinus, etc. And antibiotic based on cultural sensitivity from a specimen of the exudate from the sinus. Medical drainage by saline lavage through the nose and head tilting to allow gravitational drainage through the highly located maxillary ostium in the middle meatus. And surgical drainage, the last option in case of failed previous modalities, through either intranasal antrostomy by creation of opening over the antrum in the lower part of the lateral nasal wall, which is a radical condition, or better, a functional sinoscopy. Management of tooth or root displaced into the sinus, managed primarily by localization. If it's fresh communication and displacement of the root, we can perform a suction with a gauze is covering the suction to check the retrieval of the root, or localization using radiography in delayed cases for localization of the exact location. It be performed under local or general anesthesia. The root performed if the displaced root fragment less than 3 mm and uninfected, meaning that there is no history of infection, inflammation, pain on chewing, swelling, abscess, meaning uninfected. Nothing can be performed and fibrosis will surround this root fragment. If the root is infected or more than 3 mm, it must be retrieved after localization using either endoscopic retrieval or through Caldwell lac operation, as we'll discuss. Then it should be followed with closure of oroantral communication. As closure of oroantral communication over an infected focus like remaining root will result in a spread of infection and reopening of the communication. Caldwell lac operation is simply a fenestration or opening or antrostomy over the anterior wall of maxillary sinus and surgical drainage of the sinus into the nose via an antrostomy. Here is the location of bony window above the roots of maxillary posterior teeth, where a small round burr is used to outline the window and then cautiously elevate the sinus lining, or even using a large burr to remove the whole window slowly, gently, to avoid injury of the sinus lining, or better performed by piezoelectric surgery, which usually cut the bone and stop cutting at the soft tissue. An incision is made above the mucogingival junction, 2 mm above it, and 2 vertical releasing incision. At the canine eminence and second molar respectively, then flap elevation to expose the canine fossa. Then, as we said, bone removal with burr to create the window at the canine fossa, approximately 2.5 centimeter in diameter. Then we remove the sinus pathology through an incision within the sinus lining to wash or lavage the sinus, or removal of polyp that obstructing the ostium of the maxillary sinus. Here is we perform widening of the normally located maxillary ostium that open into the middle meatus. Here is creation of another opening to allow dependent drainage to the lateral nasal wall, that's called nasal antrostomy, through the labial opening that will drain into the inferior meatus instead of the middle meatus. Then after removal of all the oxidate, pus, remaining root or even diseased sinus lining, the whole sinus is packed lightly with iodoform gauze which contain anesthetic and septic with or without antibiotic, and the free end of this gauze will be protruded within the newly created ostium to allow for retrieval and change day after day. Then the flap is repositioned and sutured. Here, what is the indication of Caldwell operation? Number 1, treatment of resistant acute or chronic maxillary sinusitis, removal of tooth or root fragments or even neoplasm from the sinus, enucleation of periapical cyst or intrinsic cyst from maxillary sinus, and episectomy in case of odontogenic infection or periapical cyst. We enucleate the cyst and do retrograde filling of the apex. Moreover, to access reduction of the orbital floor fracture, management of hematoma within the sinus or even resection of maxillary nerve in case of malignant tumors that tend to spread along the neural sheath of the nerve. Like the usual postoperative instruction for management of maxillary sinusitis or antral communication closure, the patient should apply cold fomentation for the first 24 hours and avoid any irrigation for the same period, and avoid any hot drink or food for 24 hours. Antibiotic, analgesics, and decongestive nasal drops may be prescribed, and avoid any negative or positive pressure within the sinus, like sucking through straw, whistling, smoking, or even coughing. The patient should be able to cough or sneeze while the mouth open to avoid creation of this pressure. The complication of Caldwell operation involve anesthesia of the lip, usually upper lip, cheek, and gum of maxillary teeth due to injury of the maxillary division that pass in the maxillary sinus, or antral fistula in case of dehiscence or necrosis of the flap covering the Caldwell opening, heavy bleeding, devitalization of teeth that protruding its roots within the sinus, osteomyelitis if we utilize an antiseptic technique, or incomplete removal of infection leading to spread of infection to the bone and bone marrow creating osteomyelitis.